present topic of discussion is benign connective tissue tumors. So where we will be discussing about the most commonest of the connective tissue tumors, which are involving the connective tissue stroma, blood vessels, bone, nerve, etc. So let's go into the most commonest of these connective tissue tumors, first starting with our oral fibroma. So this is a benign connective tissue tumor, which is the most common soft tissue neoplasm which is occurring in the oral cavity. And these oral fibromas, they actually represent reactive lesions that may be caused because of some trauma or any irritation. So how does these oral fibromas present clinically? So as you can see in this clinical picture, so these oral fibromas, they are most commonly seen on buccal mucosa along the plane of occlusion, that is the line of occlusion. So because that is where more of trauma and irritation will be there. And other than buccal mucosa, it can be gingiva, tongue, lips, palate. So this fibroma, it appears as an elevated nodule of normal color with that of the surrounding mucosa. So it can be sessile or pedunculated also. So how does it appear histopathologically? As you can see this histopathological picture with a superficial epithelium and underlying connective tissue. And this superficial epithelium, as always you will see epithelium with rete ridges, right? But here you can see the flat rete ridges, that is here the epithelium is stratified squamous epithelium which is stretched out or atrophied. Okay, so that is shortened or flattened rete ridges are seen here, with underlying connective tissue stroma showing dense bundles of interlacing collagen fibers. So bundles and bundles of collagen fibers you can see with dotty cells are there. They are nothing but fibroblasts or fibrocytes. So this is the histopathological picture of oral fibroma. So next we will be seeing about giant cell fibroma, which is actually a variant of fibroma itself, but it is considered as a distinctive entity by two authors, namely Weathers and Callahan. Why they have mentioned it as a distinctive entity? Because here the histopathological appearance of giant cell fibroma is very much different from that of normal fibroma. Okay, so who are the authors? Weathers and Callahan. They find it as distinctive entity. And as you can see clinical picture, it is most commonly seen on mandibular gingiva followed by maxillary gingiva. So gingiva is the commonest site, and here it can appear as an asymptomatic sessile or pedunculated nodule. And you can see the surface, it is not smooth like fibroma, but here it is bossylated or have a papillary surface. And if you see histopathological picture, here if you see our normal oral fibroma has a flat interface, right? But here it shows thin elongated rete ridges. As you can see, numerous rete ridges are there in the epithelium. Whereas within the connective tissue, you can see the big cells are there. They are nothing but fibroblasts, which are large, plump. They can be either spindle shaped or stellate shaped, and sometimes these fibroblasts can present multinucleated, so it will look like a giant cell. That is why it is called as a giant cell fibroma. Okay, so here what you have to remember is spindle shaped or stellate fibroblasts which can be multinucleated. So this is about giant cell fibroma. Next is central giant cell granuloma. It is a pretty much aggressive tumor compared to the other two. So it is a benign proliferative lesion where we doesn't know the etiology, and the most common site is anterior mandible. So it mostly occurs in younger people, that is less than 30 years. Female predilection is more, and as I told you, it occurs in the anterior mandible, and it can even cross the midline. So this crossing the midline, it is a rare feature seen in only few tumors. So this is a lesion which is seen in the anterior mandible. Okay, and central giant cell granuloma, it can be of two types, that is it is an aggressive variant and a non-aggressive variant. If you see aggressive variant, where if the lesion belongs to aggressive, so the patient may present with the pain, a cortical perforation or root resorption. So it damages the adjacent structures basically. So whereas if it is non-aggressive, then the lesion will be slow growing and it doesn't show any root resorption, or it doesn't show any cortical perforation, that is it doesn't show any bone perforation. So like this two types are there. And if you see radiographic picture, so as you can see here, it is a radiolucency which is occurring in the anterior mandible, and you can see the deciduous teeth, right? So it is a younger adult, where you can see the radiolucent lesion is with smooth or ragged borders with definite vacuolations within them, and it might cause cortical perforation sometimes, and also thin expanded cortical plates also. So this is about radiographic picture. So how does it appear histopathologically? Histopathologically, you will see giant cell granuloma, right? So numerous multinucleated giant cells will be seen throughout the connective tissue, and these giant cells can be of variable size and contains very few to dozens of nuclei. In between these giant cells, you can see some hemorrhagic areas where extravasated blood vessels are seen, right? So and also, if at all there is this old extravasated blood, they can turn into hemosiderin, which can appear as a brown pigment like here. So but the thing here is central giant cell granuloma, that giant cell, what is the origin of this giant cell basically, from where they are coming? So the origin of giant cell is from monocyte macrophage precursors, which later becomes osteoclast. So the origin of giant cells is mostly osteoclast like. Okay, so this is about central giant cell granuloma. So next we will be looking at lipoma. So lipoma, it is a benign neoplasm, slow growing neoplasm of mature fat cells, that is adipose tissue. Okay, so if you see, though it is a very common benign tumor in the whole body, but intraorally, that is oral and oropharyngeal region, it is a relatively uncommon lesion. So orally it is a rare lesion. So how does this lipoma occurs? Usually it will be developmental, but if it doesn't develop in the younger life, if it is developing in the later life, it can be because of trauma, chronic irritation, infection, or any hormonal imbalance. Or sometimes it can be because of some chromosomal rearrangement of 12th chromosome, 13th chromosome, or 6th chromosome. So this is about the etiology of lipoma. So how does it appear clinically? Clinically, there are three variants, that is, it can be superficial lesion, it can be a diffuse lesion, or it can be an encapsulated form. If you can see in this picture, the picture which is there here, so this is a superficial lesion which is a single one and a lobulated one, and it is a painless lesion which is pedunculated. Sometimes it can be sessile also, and as you can see, it is yellow in color because of the presence of fat, and you can see there are superficial blood vessels also which you can appreciate on the top, and these will be very soft to palpate. This is about superficial lesion, whereas diffuse lesions, they will more present like a cystic lesion, okay, because they are present in underneath the tissue. So this is about a single lipoma. So there are sometimes multiple lipomas which are present associated with some conditions like neurofibromatosis, Gardner syndrome, multiple familial lipomatosis, and Proteus syndrome. So this is about clinical. Whereas histopathologically, how does it present? Histopathologically, lipoma, it is composed of mature adipocytes in between the collagen tissue. So these are all these polygonal cells with a clear space, right? These are all adipose tissue, that is fat cells, adipocytes. So this is a tumor of adipose, and sometimes this lipoma histologically contains various variants. Fibrolipoma, wherein lobules of fat cells are intermixed with fibrous component. Next is angiolipoma. Angio means blood vessels, right? So admixture of mature adipocytes with small blood vessels. Myxolipoma, it is where in the background of these mature adipocytes you can see myxoid tissue. Spindle cell lipoma, where other than the lipomatous component, you can even see spindle cell proliferation. So you can see here clear white cell proliferation, like that you can see spindle cell proliferation also. These are all variants of lipoma histopathologically. Next, very important one, it is a hemangioma. So it is a true neoplasm, and sometimes it is also considered as a hamartoma of endothelial cells. What are endothelial cells? These are basically cells which are lining the blood vessels, and these are the cells which can form blood vessels also. Okay. So hemangioma, what is the nature of hemangioma? Usually hemangioma is not present at birth, but it can occur after 1 month of life, and it initially it proliferates very rapidly, and after some time in life it will start to involute, that is it decreases in size, that it is not at all existent. So this is how it will be, its nature will be. So commonly intraorally it can be present on the tongue, and other sites are also there, and it can be present as a flat or raised lesion, usually deep red or bluish red like it is seen in this picture, and it is very well circumscribed also. Sometimes the tumor, it is often traumatized and it can also show ulceration also. So this is about intraoral hemangioma, where other than tongue it can occur in lips, buccal mucosa, palate also. Other than this, sometimes it can even occur within the bone. It is called as intrabony hemangioma or central hemangioma. If you see that a posterior mandible is the commonest site in the oral cavity. So as you can see in this radiograph, there is a radiolucency, okay, which is seen periapically to the premolars and the molar, and you can see that radiolucency is of honeycomb pattern, and it is even causing the root resorption of the premolars as well as the molar, but the vitality of these teeth will not be lost, even the root resorption is there. So it is showing honeycomb pattern. Sometimes it can even show sun ray burst appearance like that of osteosarcoma also. Sometimes the radiographic picture can also resemble an ameloblastoma too. So this is about hemangiomas, radiographic picture, intrabony hemangiomas. So this hemangioma can even present along with some syndromes. So we will discuss about the commonest syndromes associated with hemangioma. First one, Osler-Weber-Rendu syndrome, which is also called as hereditary hemorrhagic telangiectasia. Hereditary hemorrhagic telangiectasia, like in the name itself, hereditary. So it is mostly presents with autosomal dominant inheritance, and actually it presents with a triad. It consists of a triad of telangiectasia, recurrent epistaxis, and a positive family history for the disorder. So these telangiectasias are nothing but these are dilated blood vessels, sometimes present like spider-like veins, okay, and recurrent epistaxis, that is bleeding from the nose, will be there, and positive family history, any family member must be having the same disease. Okay, so this is the triad of Osler-Weber-Rendu syndrome. As you can see in this picture, intraoral picture, where the tongue is showing multiple telangiectatic lesions on the, like telangiectatic spots on the surface of the tongue. So what is the main cause of Osler-Weber-Rendu syndrome? It usually occurs as an inherited defect, as we told, autosomal dominant. So the defect will be in the 9th chromosome and 12th chromosome. 9th chromosome, it codes for vascular endothelial cells. So endothelial cells will be defective, that is why we will see telangiectasias and epistaxis. 12th chromosome, it codes for transforming growth factor beta, which is a growth promoting. So there will be proliferation of endothelial cells. So this is about Osler-Weber-Rendu syndrome. Next we will see Sturge-Weber syndrome. It's also called as Sturge-Weber angiomatosis, or it's also called as encephalotrigeminal hemangiomatosis. So encephalo, that is brain, trigeminal, that is a trigeminal nerve related hemangiomatosis. So it is a non-hereditary developmental condition. As you can see, Osler-Weber, it was hereditary, whereas this is a non-hereditary developmental condition which involves organs like eye, skin, and central nervous system. So when this syndrome occurs in eye, skin, and central nervous system, we can see if it is in the skin, we can see portwine nevi. If it is in the central nervous system, we can see intracranial calcifications. If it is occurring in the eye, we can see ocular involvement in the form of glaucoma or exophthalmos. Okay, so what is this portwine nevi? Usually it is the skin discoloration, as you can see in this picture, where there is unilateral discoloration of the skin, that is wherever the trigeminal nerve is involved, right, only till there. So that is one feature, that is portwine nevi. Next one is intracranial calcifications. As you can see this radiograph, it is the second feature, wherein the calcifications are seen within the central nervous system. It resembles tram-like calcifications. So you can see those parallel lines, right? So those are tram-like calcifications. If you see intraoral features of the Sturge-Weber syndrome, it can cause angiomatous lesions which can cause enlargement of gingiva, buccal mucosa, tongue or lips. Here you can see gingival enlargement where these hemorrhagic areas can bleed very profusely. So this is about Sturge-Weber syndrome. So next we will see histopathology of hemangioma. So it can present in two types, that is capillary hemangioma and cavernous hemangioma. So this picture is of capillary hemangioma where you can see well defined capillaries, multiple capillaries you can see, which are lined by plump endothelial cells, and in each capillary you can see those RBCs, right? So it is filled with hemorrhagic RBCs. Okay, that is about capillary hemangioma. So smaller blood vessels and plump endothelial cells. Second picture is of cavernous hemangioma where you can see large blood vessels, right? So it contains dilated blood sinuses which contain numerous red blood cells, and it contains thin lining, not like capillary hemangioma. So next lesion is lymphangioma. So it is a benign hematomatous lesion of lymphatic vessels, and this lymphangioma, it is being classified by Watson and McCarthy into various types. The variants are simple lymphangioma, cavernous lymphangioma, cellular or hypertrophic lymphangioma, diffuse systemic lymphangioma, cystic lymphangioma, or it's also called as cystic hygroma. So these are the variants of lymphangioma. But if you can see clinically, the most common site intraorally is the tongue. As you can see this here, tongue is involved. Other than tongue, palate, buccal mucosa, gingiva and lips are also involved. So anterior dorsal part of the tongue was most frequently affected, and you can see some irregular nodularity on the surface, right, which contains grey and pink projections. So this is the commonest sign of this disease, that is lymphangioma. And whenever lymphangioma involves tongue, it can result in macroglossia, that is enlargement of the tongue also. And if you see histopathology of lymphangioma, you can see epithelium. Immediately underneath the epithelium you will see connective tissue, right? So total connective tissue is replaced by these large lymphatic vessels. So each lymphatic vessel, again, it is lined by a layer of endothelial cells, and you can see some pink area within the lymphatic vessel, right? That is all is lymph. Okay, so this is about lymphangioma histopathology. Under histopathology of lymphangioma, you have variants like lymphangioma simplex. It resembles our capillary hemangioma. Okay, so next is cavernous lymphangioma where it contains dilated lymphatic vessels. Okay, same like cavernous hemangioma. Next one is cystic lymphangioma. So here it consists of huge macroscopic lymphatic spaces. Very big lymphatic spaces will be there, surrounded by fibrovascular tissues. Next is benign lymphangiendothelioma. Here the lymphatic channels will be appeared like they will be dissecting through the collagen bundles. So such big they will be, and they will be dissecting the collagen bundles. So this is about lymphangioma. Next we will see about bony lesions. First one is torus palatinus. So torus palatinus, it is actually a slow growing lesion which is seen in the midline of the hard palate. And how like there are various hypotheses which are given, like genetic and environmental factors like masticatory stress. Okay, as you can see here, torus palatinus, it is presenting as a bony hard mass which is presenting in the midline of the hard palate. It's a bony hard mass seen in the midline of the hard palate, and depending upon the shape of the lesion, okay, so it can be flat, it can be spindle shaped, it can be nodular, or it can be lobular also. So these are different shapes of torus palatinus. And if you see the mucosa overlying the torus, it is very intact, and as the lesion grows, it can even show blanching. So sometimes it can show ulceration if it is traumatized. So this is about the clinical picture. So if at all you take any intraoral palatal radiograph, this lesion can be completely made of dense compact bone, or sometimes it can present with the central cancellous bone surrounded by a shell of compact bone. So this is the intraoral palatal radiograph feature of torus palatinus. Next, as we have discussed torus palatinus, next is torus mandibularis. So actually this is an exostosis or outgrowth of bone which is seen on the lingual surface of the mandible, as you can see in the picture. lingual surface of the mandible, it's an outgrowth. So how does this develop? So it develops as a result of torsional stress, which because of the heavy mastication. Okay, because of the heavy mastication there will be torsional stress, because of which these torus mandibularis develops in this bicuspid area. So if you see clinically, so it presents as a growth on the lingual surface, as you can see, that too above the mylohyoid line and usually opposite to that of the bicuspid teeth. So it is on the lingual side of the mandible, above the mylohyoid line and opposite the bicuspid teeth, and it also varies in its size and shape, and usually it will be bilateral, but sometimes it can be even present with unilateral appearance. So after this we'll see neural lesions. First one is a neurofibroma. So it is neurofibroma, so it is of nerve tissue origin, benign tumor of nerve tissue origin. So derived from cells of nerve sheath. The cells of nerve sheath are nothing but perineural fibroblasts, which are of neuroectodermal in origin. So nerve tissue origin, where it contains perineural fibroblasts, derived from perineural fibroblasts. So usually it is neurofibroma is solitary, that is it presents as a single one. Sometimes it can be multiple also. If you see a single one, it presents as a non-ulcerated nodule, which tends to be of same color of the normal mucosa. It can be seen on buccal mucosa, palate, alveolar ridge and tongue. So if it is presenting in the tongue, it can result in macroglossia. So as I told you, it is a solitary lesion, but if it is presenting in multiple ways, like here in the second picture, so multiple neurofibromas, this is a neurofibromatosis, which is also called as von Reckling-Hossen's disease. It is a genetic condition. So there are some diagnostic criteria to define a neurofibromatosis. That is either it should contain 6 or more capillate macules, that is pigmentations, or it can have 2 or more neurofibromas, or it should have freckling in the axillary or inguinal regions, optic glioma, 2 or more lesion nodules, a distinctive osseous lesion, or a first degree relative, that is a parent, sibling or an offspring with already neurofibromatosis 1. Okay, so this is about solitary one and multiple one. If you see histopathologically, neurofibroma, it is composed of proliferation of spindle cells. See the arrow is pointing towards a spindle cell with a thin wavy nuclei interspersed with delicate connective tissue fibrils. So it contains thin wavy spindle shaped cells with connective tissue fibrils. So this is about histopathological feature of neurofibroma. The next one and the last one is neurilemoma, which is also called schwannoma. In the name itself it is there that it is derived from Schwann cells. It's a benign tumor of Schwann cells. So the most head and neck are the most common regions for the development of neurilemoma, and as you can see here, the most commonest site for neurilemoma is the tongue, and here it presents as a single circumscribed nodule, but it doesn't contain any characteristic features. But histopathologically it has the characteristic pathognomonic features, that it contains 2 types of areas. As you can see in this histopathology, you can see 2 different areas, right? So one is Antony type A and Antony type B. If you see Antony type A, here there will be proliferating spindle shaped cells which are exhibiting palisading. As you can see here, palisading spindle shaped cells are there. In between 2 rows of this palisading spindle shaped cell, you can see an acellular hyalinized region, right? That is called as a Verroque body. So Antony A is a regular palisading arrangement of spindle shaped cells with Verroque body, whereas Antony B, it is quite opposite to Antony A, disorderly arrangement of these spindle shaped cells. It doesn't exhibit any palisading or any arrangement. It is disorderly arrangement of cells and fibers. So this is about histopathology of neurilemoma, and it also marks the end of benign connective tissue tumors, and we have discussed the most common benign connective tissue tumors. So all of these which we have discussed are very important short note questions which you can expect in exams.